So greetings from Cochin. In spite of the lockdown and Corona business, the visitors to Cochin has come down drastically. But this photograph and this slide is just to remind you of something good in Cochin, to get back old memories if at all you have visited Cochin earlier. Good morning once again, and welcome to Diabetes Digital Dialogues. This mask we have seen for the last 6 months, and we are wearing it and we are seeing in society. So I might say that the true nature of diabetic foot is often hidden. So it is diabetes foot is mistaken by identity. That is the topic for today. So that is how the diabetic foot is hidden behind the mask of clinical problems. So I'll just give you a short case journey of a patient who's 53-year-old male diabetic, pain and swelling of the left leg after trivial trauma. It was initially managed by a local surgeon who treated it with the outpatient with oral antibiotics, and 2 to 3 days the pain and swelling increased in the leg. And hastily he did multiple incisions, and then when he did the incisions, he realized the extent and severity of the infection. And he was referred to me by the person for further management to me. So on examination, this I'm sure many of you would have seen this type of cases in your practice. Patient was in severe pain and he was febrile. The left leg and the posterior medial aspect was severely infected, multiple incised wounds with deep pus and multiple necrotic skin blisters. And the ankle movement was extremely painful and restricted, but fortunately his pulsations were intact. I will not go too much into the laboratory details, just to quickly say that obviously this is a case of a necrotizing fasciitis. And how I manage this is the next few slides will show you how the management and what is hidden underneath this mask of clinical problem on the surface. So medically management, we have an excellent diabetic medical team, and that was medically managed, intravenous antibiotics, and promptly was taken for surgery as a stage 1 procedure. Incision and drainage, debridement of all the slough and extension area around the posterior and medial ankle and the leg. And regular dressings and ankle immobilization was done. But unfortunately, by the time you opened it up, the tendo Achilles was full thickness necrosis was there. So this is the classical features of necrotizing fasciitis, where once you open it up, you see all the undermined tissues which are all dead and necrotic, including the fascia also. This is the defect after the debridement of the skin. Now you can see the tendo Achilles is open, and the rest of the wound has been debrided, including the intermuscular septae and the tissues around the posterior tibial vessels. Now this is a few days after the first dressing, and then you can see still the posterior tibial, the tendo Achilles is promptly jutting out, and the rest of the wound, probably the surrounding skin is all, inflammation is down. And this is the posterior view of the same leg. So stage 2, after counseling and talking to the patient, obviously the tendo Achilles has to go, because it was a full thickness necrosis. There was no chance of a salvage, unlike in trauma where you can go for a free flap or a pediculated flap. And then once the tendo Achilles was excised, then in the stage 3 later, he underwent a skin graft and gradually had ankle mobilization and gradual weight-bearing walking. So just taking you through the stages of the skin graft. This is the skin graft on first dressing, and this is the well-settled graft after a few weeks, and the patient is able to, and this is what it was earlier. You can see the amount of mistaken identity which was done by the initial surgeon, which is a classical case of mistaken identity. And then the graft is settled well. And now the patient is with the ankle. He's, in spite of losing the tendo Achilles, he's able to weight bear and walk, and the wounds are fully healed. So this is a late post-operative view. So what are the inaccuracies in this particular case of a case journey, if I might say, is the underestimation of the extent and severity of the infection had occurred. OP treatment, a very light treatment. I don't blame my previous colleague, but still it is the laboratory and clinical features, except for the pain, are very, very superficial. And then hasty incisions were made in our patient room, and delayed diagnosis, and obviously 3 or 5 days later the delayed referral. So what are the positive outcomes in spite of all these inaccuracies, where promptly the problem was identified? Inpatient treatment, patient was admitted, parenteral antibiotics were given, aggressive debridement and near complete excision of all involved tissues was done, and effectively communicating with the patient about all aspects of the problem. Good wound care, complete and effective wound healing, and reasonable functional recovery despite loss of tendo Achilles. And potentially, as you all know, severe morbidity and amputation was avoided. I will not go much into the other laboratory details, but just to give you an idea about how we can have mistakes in our clinical practice. So necrotizing fasciitis, most of you are aware, it is a pain without skin signs or pain out of proportion to physical signs. And majority of cases are misdiagnosed, and there should be a high index of suspicion and low threshold for surgical referral. And prompt diagnosis can decrease risk of death and disfigurement. Very, very important. And it is very likely many of the cases are passed off as cellulitis, but it's important to know the key differences of cellulitis versus necrotizing fasciitis. The infection starts much superficially, whereas necrotizing fasciitis is deep. So when the skin manifestations come, it takes some time. Epidermis and dermis are involved early, and in necrotizing fasciitis only later on. So you see the skin signs much later. And pudioerance is seen early. Here it is not obvious. So here, when I put up this phrase, how promptly all of you would have identified the mistake in this phrase. So promptly that we also should have a prompt diagnosis of necrotizing fasciitis. In fact, I'm very happy that many of our casualty senior officers can immediately make a diagnosis of necrotizing fasciitis and inform me at the earliest. So that should be the promptness with which you have diagnosed. I think experience counts in recognition. Now, this is some of the few cases of showing that in spite of what you trivially see on the surface or some blisters will end up with total loss of tissues because everything is infected and necrosed. Similar case, a thigh abscess with the localized necrosis, excision first stage, and then later on, once the granulation appears, we do a skin graft. Similar case, again, the same principles, and a skin graft is done for complete wound healing. This is another lady who had been to Kedarnath long time. This is around 20 years back when I started my practice, and then we did the serial debridement, and ultimately the grafting was done. So you can see the first slide where it was so small blisters, a little bit of necrosis in the ankle area, but what you actually see underneath is very, very devastating. So since I've just gone through a short case journey, I'll just to highlight the problems of mistaken identity in diabetic foot. Why are they missed? Because as you know, many of the neuropathic patients, the pain is not there, so they continue to bear weight, and there is shearing and pressure forces. The signs and symptoms of obvious infection are very often absent, and patients are, of course, low awareness is there, and you know the tip of the iceberg phenomenon classically in diabetic foot. So basically, this is what the pathogenesis, where the pain is absent and the healing process is also delayed, leading to foot ulceration. So again, very important is the anatomic, physiologic, microbiology and pathology in diabetic foot. The foot has several intercommunicating compartments. Those infection spreads very rapidly. And the soft tissues are all, many of them are avascular and they cannot resist infection like in any other parts of the body. And physiologically, the soft tissues are hypoxic because of AV shunting or peripheral vascular disease. And plantar tissues become thick, you know. And obviously, there is a background immunocompromised trait. And paradoxically, in diabetics, the infection results in microthrombus rather than a vasodilatation. And at the end of the toes, the end arteries become gangrenous. And again, there is an impaired wound healing process and persistent abscess. So all these put together lead to a problem of classical diabetic foot. This is an important slide because very often we see these patients may present with pain in a previously insensate. You should be doubly pulling up your socks when you see these patients. Pain in a previously insensate foot. Patient complains of pain. Inflammation is distant from the skin wound. There is evidence of systemic toxicity. Some will have deterioration of glycemia control, acidosis, azotemia, electrolyte abnormalities. Anything can be the presenting symptoms, whereas you have to examine the foot to find out the subtleness of the problem. And persistent progressive infection or elevated inflammatory markers despite appropriate. You feel that you're doing everything properly, but nothing is really improving. And in fact, in the presence of ischemia, peripheral vascular disease, the clinical findings will be very trivial and it can worsen the prognosis. So better to evaluate in detail. And some of these markers, you all know that will increase the bad prognosis in diabetic foot infections. So here, if I just give you a challenge to identify what will be the end result of the debridement after this, what you're seeing, this infection, we might, very inexperienced people might say this might be the result. Some will go and say this might be the presenting wound. And even more experienced will say that this will be the biggest one, which we can ultimately lead to the defect of the skin. But and similarly, the lower foot also, you might say this one or this one. But ultimately, what has happened when you go in and explore, you see the extent of the wound which has happened, because the distal and proximal, there's always a hidden element which you obviously don't see on the surface. This is another classical picture. Again, you see this. This is a case of a big blister, some pain in the leg. and nothing else, a little bit of redness around the foot, in the dorsum of the foot. But when you actually open the blister, it might be just probably look like a burn blister, but actually when you open it, you see that is the beginning of the exploration in necrotizing fasciitis. And this patient obviously had a large area of skin loss and soft tissue loss over the dorsum of the foot, as well as extending to the anterolateral aspect of the leg. So in diabetic foot infections, very obviously what we have to do is sometimes we have to take treatment decisions based on only clinical findings than waiting for the laboratory microbiology and radiology reports. That is how diabetic foot is often treated. And another important thing is the osteomyelitis is one condition which is often missed. So some of the key points in identifying osteomyelitis are listed. Many patients come with non-healing wounds, swollen toes, not healing for months together. And you just take a simple X-ray, you'll find out that there is underlying osteomyelitis. So we have to treat that before the wound heals. So this is the problems of osteomyelitis, which can also be of a case of mistaken identity. So that ultimately the osteomyelitis is identified and the ulcer heals. Then coming to the problem of day-to-day, we identify our chronic patients with Charcot's, who you don't know whether it is a Charcot's or a Charcot or a cellulitis. So these are key differentiating features which will help you to identify or at least suspect that there is Charcot's rather than a cellulitis. And the most key important thing is the short duration in cellulitis, whereas Charcot's it will be a few weeks or months. So there is you have to ask the history. And obviously in Charcot's there will be not much of pain, whereas in cellulitis there will be intense pain. And neuropathy will definitely be a history in Charcot's, whereas in cellulitis it will not be there. So this is regarding the differential diagnosis. And these are important aspects of Charcot's foot, which classically reveal that in a apparently normal foot, in a normal subject, if he has redness, then unlikely it is Charcot's. There is a pre-existing ulcer in a normal patient with an ulcer in a forefoot region. So that is also unlikely to be a Charcot's. Or when you suspect Charcot's, usually it is a midfoot ulceration. And there is a history of neuropathy with or without an ulcer, then more so in favor of a Charcot's. And there might be an osteomyelitis in a pre-existing Charcot's, which you have to differentiate by doing a scintigraphy. And osteomyelitis of the tarsal bones per se with an ulcer is more likely to be an osteomyelitis than a Charcot's with the history of neuropathy or absence of pain. And when there is a simple joint trauma fracture, of course, dislocation, you can take an X-ray or an MRI. So this is just to highlight the findings in Charcot's, which will give you a pathway to identify. This is again a case of Charcot's. You can see the problems here. The another probably common mistakes we commit is confusing between cons and calluses. Cons are benign, I suppose. In a diabetic, more important is calluses, because you have to identify the key differences between a con and callus before treating them. Because callus, in the sense, in the context of diabetic foot, you'll have to be extremely careful in exercising and preventing life-threatening or limb-threatening complications. So these are the important differences between the con and the calluses. You know, the callus can be origin of a highway to amputation, because they pass the pus or the infection goes under through the tenosynovial sheath, can ascend rapidly and cause severe infection leading to amputations. This is how a con is treated sometimes with excision and spontaneous healing. Another important thing to prevent any mistaken diagnosis in case of diabetic foot is to identify ischemia, necrosis, pre-gangrene and gangrene. So here it is important, because if you miss the pre-gangrene or the gangrene problems, the patient might be very violent or very, very agitated. So with proper counseling, so it's important to avoid any bad blood by properly identifying and treating. In this patient, there was a skip of the gangrene from the second toe to the fifth toe, and those both were amputated and debridement, and later on a skin graft was done. This is around 2 years back, and now this is actually taken last week. Patient developed a callus in the forefoot, but still the toes are viable and edema is down. So this is another case where you have to identify, do it in stages, inform, counsel, communicate, and properly identify and do it in stages, and you will get a full plantigrade foot, which healed result in a gangrene of the infective gangrene of diabetic foot. Non-healing ulcers. There are many ulcers which don't heal in diabetes. It is very important to identify the key cause of diabetes. These are some of the causes which are very common causes, but in a particular given case, it can be a single or many causes. So you have to identify the cause and correct these causes. And I'm sure many of the diabetic ulcers will heal if you identify the cause or causes and appropriately tackle them. This is an elaborate slide. I'm not going to tell you anything about this, but just to know that this is the differential diagnosis of lower extremity ulcers. Many of you would have come across many of these issues. It is important to identify and treat them. I'll just elaborate on a few of this. Pyoderma gangrenosum, you know, the differences between a diabetic foot and pyogenic pyoderma gangrenosum. In pyoderma gangrenosum, the diagnosis is mainly by exclusion on the basis of clinical progress, underlying disease, and a biopsy, which is causes dense neutrophilic infiltration. And antibiotics primarily will not have any effect. And in fact, you have a phenomenon called lethargy, where the debridement, which is usually done in diabetic foot, which causes improvement. In pyoderma, it causes an aggravation of the problem. And once you do the biopsy, then you can probably start them on steroids. And you know the differential diagnosis, again, the elaborate workup which you'll have to do. So this is a few cases of pyoderma gangrenosum, which ultimately after starting steroids, it is debrided and then ready for a skin graft. Now this is another case of mistaken identity where you see these ulcers not healing, and this obviously they can go off as diabetic foot ulcers, but you should remember that malignancy can also be a possibility. So what is mistaken by identity can be malignancy by biopsy. So some of the common malignancies are malignant melanoma, which often occur in the heel area, plantar area. And one good thing about these malignancies, you can remember this mnemonic cubed, where they say if a pedal lesion displays any two of the features of cubed, the biopsy is warranted. That is how they say in these cases of malignancy or suspected malignancy. So more easier way of knowing it is a pedal lesion with questionable cause, painless, of unusual anatomical site, pigmented, atypical, and that do not respond to standard therapy, then it has to be biopsied. So that is regarding the mistaken entity in a malignancy. So this is a case of malignant melanoma which underwent inguinal node dissection as well as wide excision of the heel and a skin graft and a posterior ortho-wedge footwear subsequently for weight-bearing walking. So just to come to the last few slides where I say that mistaken by identity, you correct it by cognizance. You need to have a high index of suspicion, low threshold for surgical referral. It helps us to appropriately plan surgery. The patient and bystander have to be involved in the discussion. Prevention is by targeting the risks, education of the patient, and obviously, as you all know, prompt diagnosis will decrease the morbidity and mortality and will improve the outcomes of diabetic foot surgery. So this is just a quick recap of all the risk factors involved in diabetic foot. And if you rearrange this, probably you will reach this mnemonic, and any coincidence to the first few letters coinciding with the organizers of this lovely conference is purely coincidental. But these are the risk factors which you have to identify and double up your stocks and prevent diabetic foot infections and ulcers in these patients. Cornerstones of ulcer prevention, it depends on what are you identifying, LOPS or PAD. You will have to call them 1 in 2, 3 months, 6 months, 12 months, depending on the risks involved. Routine inspection of the feet. I don't need to elaborate this, just to highlight that in these slides. Early identification, this is very important to communicate to the routine diabetic foot patients, especially with neuropathy. Any of these individual factors, you will have to tell them that you have a fever without a cause, pain in a previously inside foot, worsening hyperglycemia, swelling, redness. All these things, if they identify, please come to the physician, promptly identify and refer to the surgeon, which can go a long way in preventing mortality and morbidity in diabetic foot. In the context of COVID, probably we can redo our diabetic foot education and family and patient education list by comparing with the preventive tips in COVID as well as diabetic foot. And ultimately, the message will be to stay safe. That will be the message for this today's talk. So ultimately, with all this, realizing these mistakes and misdiagnosis and misjudgment and mistaken identity, if you can cross these barriers, then you can improve the outcomes in diabetic foot surgery, which the next 2 slides will show you, which will end my lecture. One more slide will show you the problem and then the healed result. This is the last slide. If I'm allowed to continue this last slide. This is again necrotizing fasciitis. So I thank the organizers for this, giving me this opportunity, and I will like you to take you the take-home message. You take a pledge today to save your patients of diabetic foot problems. Thank you.